الخير. First of all, I'd like to introduce myself. My name is Dr. Shaimaa Fathi, lecturer of internal medicine, endocrinology, and diabetes, Cairo University. And today I have the great honor to talk to you about my topic, obese diabetics. First of all, I'd like to start by introduction and remind you all that overweight and obesity are defined as an excess accumulation of adipose tissues to an extent that impairs both physical and psychosocial health and well-being. There is strong and consistent evidence that obesity management can delay the progression from pre-diabetes to type 2 diabetes and is beneficial in the treatment of type 2 diabetes. Now, what about the link between obesity and type 1 diabetes? When we say obesity, we usually think about type 2 diabetes, but what about type 1? The etiology of type 1 diabetes indicates a joint contribution of autoimmune, environmental, and genetic factors. Increasing body weight in young age groups increases the risk of developing type 1 diabetes. There is an inverse relationship between the body mass index and age at diagnosis. This is explained by the fact that more weight accelerates insulin resistance, leading to development in type 1 diabetes in individuals who have an autoimmune process going on and are already genetically predisposed. Now, what about obesity and type 2 diabetes? Adipose tissue affects metabolism by secreting hormones, cholesterol, and other substances, including leptin, cytokines, adiponectin, and pro-inflammatory substances, and also releasing non-esterified fatty acids. In obese individuals, the secretion of these substances will be increased. These substances are involved in the development of insulin resistance, and insulin resistance with impairment of beta cell function lead eventually to diabetes in adults. Now, what about the clinical approach and the assessment? At each routine patient encounter, body mass index should be calculated. Body mass index should be classified to determine the presence of overweight or obesity. زي ما حضراتكم شايفين في التable, body mass index is categorized into its different categories, including the overweight and the obesity class 1 and class 2 and class 3. Diet and physical activity and behavior therapy are the cornerstone for all ranges, starting من 25 لحد above 40. It is the cornerstone of treatment of overweight and obesity. Pharmacotherapy can be considered starting the body mass index reaching 27, and metabolic surgery should be done if the body mass index is above 35 and can be considered if the body mass index is above 30. وهتكلم في النقطة دي in details at the end of the presentation. Now let's discuss in more details diet, physical activity, and behavior therapy. Among patients with type 2 diabetes who are overweight or obese and have inadequate glycemic blood pressure and lipid control, lifestyle changes that result in modest and sustained weight loss produce clinically meaningful reductions in blood glucose, hemoglobin A1C, and triglycerides. Moreover, greater weight loss produces even greater benefits, including reductions in the blood pressure, improvement in LDL and HDL and cholesterol, and reductions in the need of medications, and maybe achievement of the perfect glycemic control, leading to a complete stopping of the oral hypoglycemic drugs. Significant weight loss can be attained with lifestyle programs that achieve 500 to 750 kilocalorie per day energy deficit, which in most cases is approximately من 1200 ل 1500 kilocalorie per day for women and من 1500 ل 1800 kilocalorie per day for men. Weight loss of 3 to 5% is the minimum necessary for any clinical benefit. Diets may differ, وكل patient يقدر يختار اللي يناسبه as long as the necessary energy deficit اللي أنا قلت عليه من 500 to 750 kilocalorie per day is achieved. For patients who achieve short-term weight loss goals, long-term, more than 1 year, comprehensive weight maintenance programs should be prescribed. Such programs should provide at least monthly contact to make sure that the patient is monitoring the body weight regularly and is very compliant to a reduced calorie diet regimen and participates in physical activities of 200 to 300 minutes per week. Now, what about the pharmacotherapy? When choosing glucose-lowering medications for overweight or obese patients with type 2 diabetes, consider their effect on weight. طبعا حضراتكم كلكم familiar بالdiagram ده بتاع ال ADA and I just want to point out the importance of obesity and overweight وعلشان كده ليها كولم لوحده اللي هو لونه أزرق فاتح is just discussing the drug regimen or the strategy of treatment for type 2 in those patients who are overweight or obese. طبعا we normally start with metformin and then as long as it is not contraindicated and then we see the response. Afterwards, we can add a second drug. In case of overweight or obesity, my best choices are GLP-1 receptor agonist and sodium glucose transporter 2. If hemoglobin A1C remains above target, then لو ابتديت عند عيان ب GLP-1 receptor agonist, I can use then sodium glucose transporter as a second choice and vice versa لو ابتديت بالعكس. And then I can add, if the hemoglobin A1C is still above target, I can add a DPP-4 inhibitor if none of them is reaching target or if their combination is not reaching target or if the patient develops side effects or cannot tolerate these drugs, I can move on to the other drugs that are not my best option in overweight and obese patients. والتيبل دي برضو علشان أفكر حضراتكم بإيه هم الأنتي diabetic drugs that can be used that are weight neutral or that cause weight gain or that can cause weight loss. زي ما حضراتكم شايفين في الweight loss عندنا GLP-1 receptor agonist and the metformin and the sodium glucose transporter inhibitors ودول اللي كانوا موجودين بالظبط الchoices اللي موجودة في الكولم البلو في الدايجرام اللي فات and weight neutral they include the DPP-4 inhibitors and others and طبعا weight gain هم الانسولين والsulfonylureas and the TZTs. Okay, concomitant medications. Providers should carefully review the patient's concomitant medications and whenever possible minimize or provide alternatives for medications that promote weight gain. These medications can be, for example, antipsychotics, antidepressants, glucocorticoids, injectable progestins, anticonvulsants, and antihistaminics and anticholinergics. ما اقدرش اوصل للتارجت بتاعي في الويت لوس غير لما اتاكد ان البيشنت ما بياخدش اي concomitant medication that can be blamed for weight gain. There is a group of drugs that are now approved for the weight loss, and specifically طبعا in obese diabetics. So the US FDA has approved medications for both short-term and long-term weight management as adjuncts to diet, exercise, and behavior therapy. Nearly all FDA-approved medications for weight loss have been shown to improve glycemic control in patients with type 2 diabetes and delay the progression to type 2 diabetes in patients at risk. Efficacy and safety should be assessed at least monthly for the first 3 months of treatment. If a patient response is deemed insufficient, وده معناه إن الweight loss أقل من 5% after 3 months of the usage of these drugs, or if there are significant safety and tolerability issues, at any time the medication should be discontinued and an alternative medication or treatment approach should be considered. زي ما حضراتكم شايفين في عندي short term treatment ودي بيكون اللي باخد فيها الدراج أقل من 12 weeks أو أقل من 3 ل 4 شهور وهو الفينترمين. And long term treatment include الأورليستات, lorcaserin, phentermine, topiramate, this combination, naltrexone, bupropion, and GLP-1 receptor agonist liraglutide. التيبل دي حبيت أعرض فيها لحضراتكم السايد effects of each and every group وطبعا we have at the end to weight risk versus benefit. Now what about metabolic surgery? Metabolic surgery should be recommended as an option to treat type 2 diabetes in appropriate surgical candidates with body mass index أكتر من 40 and in adults with body mass index between 35 to below 40 who do not achieve durable weight loss and improvement in comorbidities with reasonable non-surgical methods. And metabolic surgery may be considered as an option for adults with type 2 diabetes and body mass index between 30 to below 35 who do not achieve durable weight loss and improvement with non-surgical methods. Metabolic surgery should be performed in high-volume centers with multidisciplinary teams. Exceedingly few pre-surgical predictors of success have been identified, but younger age, shorter duration of diabetes, non-use of insulin, maintenance of weight loss, and better glycemic control are consistently associated with higher rates of diabetes remission. أيا كان أنا هختار which type of bariatric surgery بيبقى فيه عندي some predictors that can tell me if the patient might have diabetes remission after surgery or not. Longer-term concerns include the dumping syndrome, including nausea and colic and diarrhea, vitamin and mineral deficiency, anemia, osteoporosis, and rarely severe hypoglycemia. People with diabetes presenting for metabolic surgery also have increased rates of depression, and this is why I should put all these concerns into consideration in order to manage them properly after surgery. Now, my take-home message for today is diabetes and obesity are chronic disorders that are on the rise worldwide. Body mass index has a strong relationship to diabetes and insulin resistance. Gaining weight in early life is associated with the development of type 1 diabetes, and new approaches in managing and preventing diabetes in obese individuals must be studied and investigated based on these facts. I hope أكون لميت الموضوع properly in 10 minutes. Thank you very much. Stay safe and stay positive.